Welcome back to our exam prep podcast. Today's topic is CVDs, cardiovascular diseases. Dr. Joshi, could we start with a crisp definition that students can reproduce in the exam?
Cardiovascular diseases are disorders of the heart and blood vessels, chiefly coronary heart disease, cerebrovascular disease, heart failure, rheumatic heart disease, and peripheral arterial disease. In community medicine, we focus on their population burden, risk factors, and prevention across levels, from primordial to tertiary.
Great. Before we dive deeper, pause and recall which broad disease groups sit under CVDs.
Coronary, cerebrovascular, peripheral vascular, heart failure, and rheumatic forms. Remember that in low and middle income countries, the onset is often a decade earlier than in high income settings, which has big social and economic implications.
What are the key non-modifiable and modifiable risk factors students must list?
Non-modifiable ones are age, male sex, and family history or genetic predisposition. Modifiable factors are raised blood pressure, raised glucose, dyslipidemia, tobacco in all forms, unhealthy diet, high in salt and trans fats, physical inactivity, overweight and central obesity, harmful alcohol use, and psychosocial stress. Add exposure to air pollution as an emerging risk. For viva, mention raised LDL, low HDL.
Now explain mode. Could you link these risks to the pathophysiology without going too deep?
Certainly, persistent high blood pressure injures arterial endothelium, facilitating lipid deposition. This lipidemia accelerates atherosclerotic plaque formation. Tobacco promotes oxidative stress and thrombosis. Insulin resistance and diabetes stiffen vessels and promote inflammation. Over time, plaques rupture, causing thrombosis in coronary or cerebral vessels, presenting as myocardial infarction, that is MI, or stroke.
Here's case Vignette 1. A 45-year-old shopkeeper attends a community screening camp at a health and wellness center. His seated blood pressure on 2 occasions is 148 over 92 millimeters of mercury. Random glucose is 162 milligrams per deciliter. Waist circumference is clearly elevated. He chose tobacco. Dr. Joshi, how should a student reason through this?
First, classify the risk profile. He has stage 1 hypertension, probable impaired glucose or undiagnosed diabetes, central obesity, and tobacco use. Multiple risks that multiply each other. In public health practice, we do not manage numbers in isolation. We estimate absolute CVD risk. Used a WHO and International Society of Hypertension's absolute risk chart for his age, sex, blood pressure category, smoking status, and diabetes status to estimate 10-year risk. Based on moderate or high absolute risk, we intensify lifestyle counseling plus medications for blood pressure, consider statin therapy if risk is high, and ensure follow-up.
So the emphasis is on absolute risk rather than single thresholds?
Exactly. It is exam-worthy to say, treat the total risk. In busy clinics, simple rules of thumb are help anyone with very high blood pressure, diabetes with additional risks, or established disease go straight to high-risk management.
Analyze mode. Levels of prevention are core. Could you walk us through primordial to tertiary prevention for CVDs with India-specific touches?
Primordial prevention means preventing the emergence of risk factors in the first place. Urban design that promotes walking and cycling, salt reduction policies, trans fat elimination, and school-based health literacy. Primary prevention targets individuals with risk factors but no established disease. For example, tobacco cessation, dietary counseling to reduce salt and saturated fat, increasing physical activity to at least 150 minutes per week, weight management using body mass index, that is BMI, and waist measures, and evidence-based drug therapy where indicated. Secondary prevention is early detection, for example, opportunistic screening of all adults for blood pressure at every contact, periodic glucose and lipid checks for those above a certain age or with risks, and risk scoring to guide therapy. Tertiary prevention is about limiting disability after an event, say post-MI or post-stroke care, cardiac rehabilitation, adherence to antiplatelets, statins, blood pressure and glucose control, and disability support. In India, the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases and Stroke integrates population-based screening through subcenters and primary health centers. And the India Hypertension Control Initiative standardizes drug protocols and follow-up using simple low-cost algorithms.
Students often worry about what to write for screening. Could you give a crisp, reproducible plan?
Write this: opportunistic and population-based screening. Opportunistic is where one checks blood pressure for all adults at every visit. If elevated, recheck and confirm on separate days. In population-based, there are community-wide drives for adults, commonly 30 years and above, measuring blood pressure, capillary or fasting glucose, total or non-HDL cholesterol where feasible, weight, height, BMI, waist circumference, tobacco and alcohol history, and physical activity. Use absolute risk charts to triage. For example, low risk gets lifestyle advice and annual review. Moderate risk gets lifestyle plus consideration of one or more drugs. High risk or established disease gets full package, that is antiplatelet where indicated, statin, blood pressure, and glucose control with referral if complications.
Pause and recall. Which simple metrics should you record at a camp?
Blood pressure after 5 minutes seated, capillary or fasting glucose, total or non-HDL cholesterol where feasible, weight, height, BMI, waist circumference, tobacco and alcohol history, and physical activity.
Let us fold in a community perspective. Suppose a district sees rising premature CVD deaths, people in their 40s and 50s. Case Vignette 2. A block medical officer asks you to design a block-level plan using existing resources. How would you proceed?
Start with situation analysis. Use HMIS records, hospital discharge data, and, if available, civil registration to map hotspots. Next, plan 3 streams. Stream 1, in which health promotion, salt reduction messaging, home cooks and street food vendors, move more neighborhood campaigns, and tobacco cessation drives. Partner with schools and work sites for screening and activity corners. Encourage front-of-pack labeling literacy. Stream 2, in which clinical standardization takes place. Ensure each primary health center has validated digital blood pressure devices, drug stocks across 1 or 2 standard regimes, for example, amlodipine, telmisartan, and a thiazide-type diuretic, and clear referral pathways. Train nurses and ashas to do follow-ups, pill counts, and home blood pressure checks. Use simple registers or digital apps to track control rates. Stream 3, in this secondary prevention bundles at first referral units. After MI or stroke, discharge patients on the ABCDE bundle. A for antiplatelet where indicated, B for blood pressure control, C for cholesterol control, that is statin, D for diabetes control and diet, E for exercise plus education. Schedule the first follow-up within 7 days, then monthly until control.
Analyze mode. How do we measure success in such a plan?
Use process and outcome indicators. For process, proportion of adults screened, availability of drugs, proportion of diagnosed hypertensives enrolled. For outcome, control rate among registered hypertensives, mean systolic blood pressure reduction at 6 months, adherence rates, hospital readmissions for MI or stroke, and ultimately premature mortality due to CVD. A simple and powerful metric is control rate, the percentage of registered hypertensives with blood pressure under target at last visit.
Exam tip time. Students are asked about tobacco cessation in CVD prevention. What should they say succinctly?
State the 5 ways. Ask about use, advice to quit, assess readiness, assist with brief counseling and pharmacotherapy where available, arrange follow-up. Emphasize that smokeless tobacco is equally harmful for CVD risk. Community strategies include ban on advertising, smoke-free public spaces, taxation, and cessation services.
Another common short note, diet advice.
Use the DASH plus memory aid, that is dietary approaches to stop hypertension pattern. More fruits, vegetables, pulses and nuts, low-fat dairy, replace saturated and trans fats with unsaturated fats, reduce salt, limit free sugars and ultra-processed foods, adequate potassium, calcium and fiber, and maintain a healthy plate with portion control.
Students may be asked, how do social determinants tie into CVDs?
Lower education, insecure work, urban design that discourages activity, and food environments flooded with high salt, high fat, high sugar items all push populations toward risk. Therefore, multi-sectoral policies, transport, food regulation, taxation, clean air are as important as clinic-based care.
Quick rapid fire, true or false style. Raised LDL is more strongly linked to coronary risk than raised total cholesterol alone.
True, because LDL directly participates in atherogenesis. Measuring blood pressure once in a camp is enough to label hypertension. False, confirm on separate occasions unless severely elevated or with end organ damage. Absolute risk guides intensity of therapy better than a single number threshold. True, treat the total risk. For post-MI patients, exercise is contraindicated. False, supervised graded exercise is part of cardiac rehabilitation.
Before we wrap, could you give a neat, exam-friendly framework to structure a long answer on CVDs?
Start with definition and magnitude, list risk factors, outline levels of prevention, describe screening and absolute risk assessment, present initiatives like the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases and Stroke, and the India Hypertension Control Initiative. Add community clinic linkages. Finish with monitoring indicators such as control rates and premature mortality.
Perfect.